Hi, my name is Abby Grabow, and the social policy I have chosen to analyze is abortion and existing legislation that dictates a woman's access to abortion services. While the topic of abortion can be divisive and triggering for some individuals, it is crucial to assess social policy objectively and without personal biases. Keep in mind that the purpose of social policy is to promote general welfare and address societal needs. Additionally, as social workers, we are called to promote the core value of social justice. My professional stance on abortion policy and legislation is in support of a woman's right to bodily autonomy. Bodily autonomy, or the right to make decisions about one's own body, is a fundamental principle rooted in both human rights and legal frameworks. It includes the right to control one's health, make decisions about reproductive choices, and refuse unwanted medical treatment. While the primary focus of my analysis is abortion legislation, the issue of bodily autonomy and its regulation is universal and complex. The impacts of legislation limiting one's right to bodily autonomy can be seen on micro, meso, and macro levels, demonstrating that abortion is more than just a women's issue. Here in New York, this principle is reflected in state legislation that protects a woman's right to abortion. Notably, New York State made abortion legal in 1970. That's 3 years before the historic Roe v. Wade Supreme Court ruling that established a woman's constitutional right to abortion. Our current New York State Attorney General, Letitia James, strongly supports women's access to necessary medical services, including abortion. Additionally, New York legislation requires insurance coverage of abortion. New York requires Medicaid and all state regulated private health insurance plans to cover abortions. Any state regulated private health insurance plan that offers maternity coverage must also provide coverage for abortion without cost sharing. Following President Trump's appointment of two conservative Supreme Court justices, New York state legislators even went a step further to protect women's access to abortion services. Out of concern that the new conservative Supreme Court could overturn Roe v. Wade, in 2019, New York State passed the Reproductive Health Act to protect access to reproductive rights throughout the state and make the right to abortion found in Roe v. Wade part of state law. The enactment of the Reproductive Health Act was critical in protecting women's rights to bodily autonomy in New York State because, as predicted, in 2022, the Supreme Court overturned the landmark Roe v. Wade ruling, citing that a woman's right to choose is no longer federally protected, thus giving the power to individual states to decide the future of women's bodily autonomy. Following this decision by the Supreme Court, 20 states have banned or limited access to abortion services, and the negative impact is wide-reaching. So let's examine some of the stated and latent goals of New York State's legislation regarding abortion. Some of the stated goals include protecting the reproductive rights and bodily autonomy of women in New York State, protecting women's right to access safe and legal abortion, protecting those in the medical field who deliver critical reproductive health services, and expanding access to abortion care. Now, some latent goals of these policies establish New York State as a safe haven for reproductive health. They also address health disparities, namely promoting accessibility to health services for marginalized populations such as women of color, women with lower income, and those living in rural areas. Another latent goal is promoting broader reproductive justice for women. So, some unintended consequences of anti-abortion legislation. First, we see unsafe abortions leading to severe health complications and even death. Making abortion illegal does not stop women from having abortions. It only prevents them from having safe abortions. Next, we see what economists are calling a brain drain. So, young adults moving out of states with strict abortion laws, with a net loss of approximately 36,000 residents per quarter in the 13 states with near total abortion bans, which is a significant portion of the combined population. Next, we see U.S. citizens crossing state lines to access abortion services. More than 1 in 7 women who had an abortion in the United States last year crossed state lines to do so. And this is according to estimates from the Guttmacher Institution. In 2024, a report by CNN highlighted that over 2,000 women from Florida alone traveled to New York for abortion services. So another unintended consequence is medical students are now opting out of OBGYN and emergency medical specialties due to the ongoing legal and ethical issues related to reproductive services and patient autonomy. Another unintended consequence is the exacerbation of existing disparities in access to quality reproductive health care. In states where abortion is illegal, minorities and women living in poverty are disproportionately affected. Black women are 3 times as likely, and Hispanic women twice as likely to seek abortion as white women. And half of all women who get abortions live below the poverty line. These demographics are not likely to have money in order to afford traveling out of state for abortion services elsewhere or to pay out of pocket for these services. So that does raise the question, if these individuals cannot afford to have an abortion, how will they afford to raise a child? Another example of an unintended consequence includes the shortage of medical providers, especially in rural and impoverished areas. So many states with restrictions are already facing physician shortages. So fear of losing their medical license or facing criminal charges will keep physicians from practicing in states with strict reproductive health policies. Taking a quick look at economic impacts, abortion services cost insurance companies less than the cost of full-term prenatal care and delivery of a child. This is especially in cases where the child is born with major health impairments or when the mother is left with severe health issues following the pregnancy. The brain drain mentioned before, brain drain which economists are calling it, is tens of thousands of young professionals relocating from states with strict abortion bans. So this creates shortages in the job market of those states for qualified applicants. It depletes the local tax base and also negatively impacts the housing market. Another economic impact is the increase of number of children in foster care. So last year, 2024, the federal government spent just under $1.3 billion for foster care maintenance payments going to foster parents and foster care facilities. Next, we'll look at social impact. So what happens when women are denied bodily autonomy? So one result is that children may land in foster care. And currently, there are over 365,000 children in foster care in the United States. Women and children living in poverty, women and children face disproportionately high poverty rates, especially in single mother households. So this semester, during week 6, when we examined child welfare, we learned that 4.5 million children in the U.S. live in extreme poverty, and that in 2019, more than 1 in 7 children experienced food insecurity. So in addition, we're seeing significant trauma for women when they're denied bodily autonomy. So in cases of rape or incest, women are re-victimized by laws forcing them to carry an unwanted pregnancy to term, not to mention the burden that is then placed on the woman to decide what to do with the child. While bodily autonomy is widely considered a basic human right, in the United States, the Constitution has been used over time to either support or deny an individual's right to bodily autonomy, even outside the issue of abortion. A major flaw with using such an antiquated and vaguely worded guideline is that its interpretation and application has varied greatly across different legal systems, situations, and generations. So we see by some of the examples provided that issues of bodily autonomy do not only directly apply to abortion rights. We see Griswold versus Connecticut in 1965, establishing the right of married couples to use contraception. This highlights the right to privacy and bodily autonomy in reproductive decisions. Obviously, the Roe v. Wade case in 1973. In that ruling, it was recognized that a woman's right to an abortion was based on her right to privacy and bodily autonomy. In 1978, McFall v. Shimp, a Pennsylvania court ruled that a person cannot be forced to donate bone marrow, even to save a life, again highlighting the right to refuse bodily intrusion. In a current case, still active in 2025, Brene Dre versus Staten Island University Hospital. So this highlights the ongoing debate over maternal rights to refuse medical interventions such as C-sections, even if a doctor deems it medically necessary. So if citizens lose their right to bodily autonomy, it affects everyone, not just women. And when legislation begins to threaten bodily autonomy of one group, you can bet it will continue to encroach on the liberties of all. Medical autonomy is the cornerstone of medical ethics and includes the right to refuse medical treatment, the right to refuse life-saving treatment, and unwanted bodily intrusions. To demonstrate that bodily autonomy is not just a women's issue and not just related to abortion, here are two current and more universal examples of legislation denying bodily autonomy. The first being mandated COVID-19 vaccinations. Never in my life have I heard so many men embrace the ideal of my body, my choice. The second example is with the limited enactment of death with dignity legislation. So, death with dignity, also known as medically assisted death, is currently only upheld in 10 of 50 states. These laws are designed to allow terminally ill patients end their suffering and die with dignity. Not only does this spare the individual from unnecessary pain and suffering, but also protect against the accumulation of extensive medical costs that are associated with end-of-life care. So, how does bodily autonomy legislation intersect with human rights? Human rights are viewed as inherent, inalienable, universal, and comprehensive. So, relating to the Universal Declaration of Human Rights, the following articles, in my opinion, relate to the idea of bodily autonomy. So, Article 2 states that everyone is entitled to all the rights and freedoms set forth in this declaration, without distinction of any kind, such as race, color, sex, language, religion, political, or other opinion. Now, I'd like to note that the Universal Declaration of Human Rights includes the protected class of sex, while the Constitution of the United States does not specifically mention protection based on sex, primarily because at the time that it was written, it was really only applicable to white men. Women had not yet been considered at all for equal rights. Anyways, Article 3 of the Universal Declaration of Human Rights. Everyone has the right to life, liberty, and security of person. Article 5. No one shall be subjected to torture or cruel, inhumane, or degrading treatment or punishment. In Article 6, everyone has the right to recognition everywhere as a person before the law. So, in conclusion, my proposal for policy reform is simple. Bodily autonomy, along with all human rights, should be irrevocably secured by the federal government. No one should have to worry if an upcoming election will take away their human rights, and no one should be forced to travel to a different state to have his or her fundamental rights protected by law. Thank you.